The gentleman from Pennsylvania.
Well, good morning, everybody. Hope everybody had a good time last night. Did the Browns win? I don't know. No, they did.
It'll be a long year.
Okay. How about the Indians? Did the Indians win?
Yeah.
They won. 1 out of 2. Okay. Did LeBron come back? Well, yeah, as you heard yesterday, it was a great meeting yesterday. A lot of interesting discussion, a lot of debate. I hope we can repeat that today. The great thing about the American Society of Maxillofacial Surgeons is that the members, it's not it's actually a very close-knit group, as you can tell, how we banter, which I truly enjoy. And it goes to show you how we are very transparent and kind of relaxed in our discussion. And I think that's very, very important for an open, transparent, honest way of looking at problems. And I really compliment all the people on the panels yesterday for doing that. This morning I'd like to introduce Amanda Goskin. Dr. Goskin is from San Diego, and she's going to lead us into our next panel. And Amanda, I'm going to go up there and be the AD guy, so the podium's all yours. Okay.
Thank you guys very much. I really appreciate this opportunity. Frank, thank you for including me in this program. And if you don't mind, I was going to ask the presenters for the first half to just come up and sit up here so that we can facilitate the discussion. We're going to have our first session this morning on cleft lip and palate. And our first speaker is going to be Del Ma from Wisconsin. We're going to speak about revision following cleft lip repair. And we're going to have some other topics that are going to address some of the surgeries that are dealing with patients after primary repair, as well as primary rhinoplasty. So look forward to an interesting discussion, and I'll turn over the podium to John.
Thanks, Amanda. And thanks for the opportunity to talk about my experience in revision following lip repair. My disclosure is that I don't have any financial conflict of interest, but I do have lots of experience in this topic, both revising some of my own as well as revising some from the upper Midwest area. And I will also admit that this is an experiential talk and not a scientific presentation. So we all, as cleft and craniofacial surgeons and maxillofacial surgeons, hope that we can hit a home run. We see babies with extremely wide clefts, and we hope that really with one procedure we can get adequate length, adequate scar that will maintain itself over growth and time. But while I will admit that it's not always a home run. So there are some primary surgical issues to think about, particularly with the rotation advancement. Even if you do a molar modification of a rotation advancement, the crux of the matter is the under rotation, and I would consider that to be an on-table error. On a bilateral repair, a lot of the errors, if you will, on table would be really retaining excessive length of the upper lip, not setting the philtral cone where it needs to be fairly narrow, and then also getting this weird prolabial mucosa or scarring or irregularity, particularly in the sulcus for a very wide bilateral cleft lip. But that's not all. We can't blame all of our secondary revisions of primary cleft lip repair based on just what happens at 3 months of age when we're doing the primary lip repair. Some are patient factors, like what are the scar qualities of the patient? Do they develop a hypertrophic scar postoperatively? Does the scar shorten, drawing things up? giving a snarled appearance or irregularity. And then over time, what is the growth of the scar? We know from other scars that we treat, burn scars, things like this, we have to watch those throughout growth. So why would we expect that a lip scar necessarily in all cases is going to have nice, supple, smooth growth? So I just want to show some experiences that I've had in secondary lip revision. And this is a child that has even been done recently within the last 7 or 8 years. And this is a child that we did everything right for, with the exception of the surgery. You can see that this child underwent NAM. I'm a strong believer in NAM. Able to get the segments fairly close together to alleviate, a thick scar or a lot of scar tension. But then when I look back at the pictures of the on-table result, you can kind of see what's going to eventually happen. Look at that area. Let's see if we can get this to work. You can see that the white roll isn't lined up just perfectly. The lip is actually short and a bit under-rotated. And sure enough, by the time that the kid was 3 years old or so, you can see that we have a drawn-up lip, very unfavorable scar. The muscle is intact, the deep aspects are okay, the mucosa is okay. So for this type of the secondary revision, this needed a skin-only revision, and you can see I partnered that with a cleft tip rhinoplasty. So a lot of errors we can actually see on the table, and I would encourage everybody to look back whenever you get an unfavorable scar or asymmetry afterwards, to look back at your operative photos, the end-of-case photos. That's been my best learning opportunity. Now, other sort of minor things that can happen is leaving a little bit of excess mucosa. As you can see with this child, the lip elements look good as far as the muscle, the scar quality, and even the nasal profile. But you can see that we've got this extra mucosa underneath. I've always been very nervous about throwing anything away, particularly on a wide cleft like he had as an infant. This is a different kid, by the way, from the last one. But this is also a problem that needs a secondary revision. And it's just a touch-up, just a removal of that excess mucosa. But that didn't become a problem really on this kid until he was undergoing his primary orthodontia in preparation for bone graft, and that extra mucosa got in the way. Now I'm going to show you 2 tales of bad scar quality. So this is a patient with a very wide cleft, was not able to participate in NAM preoperatively, had a molar modification of a rotation advancement flap, and then 6 weeks post-op ends up with this kind of a scar. So it's drawn up, it's really thick. I'm getting very nervous at 6 weeks that oh my goodness, I'm gonna have to revise this scar, and I was happy with it on the table. But this mom was persistent. She was very engaged in scar massage, and basically at 6 months, that hypertrophic scar had actually improved quite a bit and averted any need for a scar revision or secondary lip on this child. Here he is several years later. And then I'm going to show you this little guy who had basically a similar wide cleft of the lip and palate. A similar repair, good on the table. But his scar quality persisted. So even at 3 years and at 5 years, the scar quality itself was really terrible. So he underwent a cleft lip revision. Again, just skin only as far as the rotation goes, because his muscle was good. With this time, a much better scar quality. And I can only attribute that back to excess tension from the wide cleft lip repair, that he was not a NAM candidate. And that's persisted over many, many years. Here he was just at the beginning of the summer coming back, again with a nice supple lip and good scar quality. Now sometimes you get patients, so I would call these technical errors and scar things that are a little bit out of your control. But then you do end up seeing a lot of patients that come in for secondary lip revisions that have been repaired elsewhere, that you just don't even understand kind of the motivation behind the repair. This was repaired by a non-cleft surgeon in the Wisconsin area. You can see lots of issues with this, including this very funky prolabial mucosa abnormality, a very wide filtral column, and just overall, just really not a great repair. So with this one, you have to take the whole thing apart again. You have to really start from the beginning. You have to narrow it, which she needed. She needed definitely some revision of the mucosa, and then also did a little bit of a tip rhinoplasty at the same time. And there you can see that she's got better balance. I would say my critique of this revision would be that I think it's still a little bit long, that in her future she's likely going to need a mid-face advancement, so I didn't go too crazy as far as shortening goes. And here she is before and after. Other children come from other countries where the repairs, you can't even look up what the operative note was. This is a child with a bilateral cleft lip and palate. You can see the foreshortened scar, the snarled appearance, the irregular border as far as the mucosa goes. This is a child that's going to benefit from a complete re-repair. And then here he is after the re-repair, and it's held up over time. And then also when we're talking about secondary cleft lip deformities, we have to also think about people that are adults. This is a gentleman who immigrated from another country and had a repair when he was in young childhood, but was really unhappy with the appearance of his lip and the ability to completely close his lip. As you can see here, the primary problem here is the muscle isn't repaired, so the analysis is skin, muscle, mucosa. This young man deserves a full re-repair. And you can see when those elements are reapproximated appropriately, you get a nice balance. So my clinical wisdom after 17 years of doing revisional work, as well as on my own patients as well as others, is really to individualize the approach. There's not a single operation that works for every single person. And that's because different elements need revising. Is it a muscle problem? Is it a whole complex problem? Or is it just a skin and mucosa issue? So there are lots of patients that, particularly of your own, since you're all experienced cleft surgeons, that are going to be minor skin touch-ups, a little Z-plasty at the border to really get things perfect. But there are going to be some that you're faced with, particularly from people from other countries or other surgeons that are not cleft-specific surgeons, that you're going to have to take down and redo the entire repair. So my best advice is to get it right on the table the first time. Obviously, at the end of the case, you're thinking, okay, let's get on to the next case, but don't leave the table until you're completely satisfied. As I showed in that very first case, I was a little unhappy with it at that time, but I thought that maybe it would still be okay. I learned my lesson, no, unless it's absolutely perfect and even slightly over-rotated, I won't leave. The other thing is treat the scar early and often, because as you saw in the table of those two patients that had similar clefts and similar post-op course, one really benefited from scar massage, using various things. I don't usually recommend Mederma because I think it's too expensive, but it's just really the massage that helps break up some of that scar. And then don't be afraid of revisions. This has, I would say, been my biggest renaissance. When I first started cleft surgery, I took it as a personal failing if I ever had to do a little lip touch-up. And in talking with my breast colleagues and watching the number of revisions that they do for something that's not growing, something that they have total control over, I thought, you know what, I'm not going to beat myself up over these minor revisions. I'm just going to do what's best for the kid and try to plan it at a time that they have another surgery.
much, Del. Our next speaker will be Dr. Gregory Pearson from Ohio State, and he will give us his insight on the correction of cleft lip and palate in older patients.
I'd like to also thank Dr. Pape for inviting me to talk, and also to the SMS for inviting me to talk. When I was looking at the program, I asked Dr. Pape what I should talk about, and he said, talk about surgery in older children. And I looked at the program and I thought, we're not talking about BPD, and I think that's a really critical topic that should be addressed during this conference. So that's what I aimed my talk towards. Give me 1 second, sorry about this. So I thought we'd talk about BPD. I have no financial disclosures. So the outline of this lecture is going to describe the velopharyngeal anatomy and function, define what BPD is and the incidence and etiology. I know this is going to be, for some of the attendees in the room, probably a little redundant. Discuss the evaluation of BPD, treatment options, and then common complications of BPD surgery. So this is why we do cleft palate surgery. You know, we all talk about the lip and the nose, but we all know how much quality of life is affected. But when I'm talking to you on the phone, I don't know what your nose looks like. I don't know what your lip looks like. I know what your voice sounds like. And there are definitely studies that show that people who have significant hypernasality are perceived as less intelligent and other things like that. And I think that that's a critical portion of the quality of life in people with cleft lip and palate. So let's just review the anatomy for the more junior people in the room. Again, we have the levator veli palatine that forms this nice sling. And in children with clefts, it has aberrant insertions, and so it doesn't have normal architecture. And this is another view of it coming off the petrous bone, petrous portion of the temple bone, and coming and forming this sling with the function to pull the velum, soft palate, posteriorly and superiorly. And this is just another quick view of that. So really, the idea of this is to close off our oral pharynx from our nasal pharynx when we talk and also when we don't talk, so we don't have persistent nasal regurgitation of food. I mean, all the families complain about that when the child is young and a baby and feeding, but we have to continue to think about that also as a possible symptom of BPD when they're older. So again, the primary problem in BPD is that there's inadequacy of this mechanism to completely close. And this is just a quick diagrammatic for less senior people. Again, the velum should go up and posterior, and when you have BPD or hypernasality, it's coming out through the nose. This is still a photograph of video before, and here's what you should see, and here's that posterior superior movement. I keep saying that because that's really important, because when you do surgery with these patients, you want to make sure that you're trying to put the surgical intervention at the point of contact. So again, this is a structural or functional issue. Some people also call it EPI, velopharyngeal insufficiency, inadequacy, and incompetence. But more and more people think that BPD, because it just describes the dysfunction that the valve isn't closed during speech, is probably the most comprehensive term. So what are the symptoms of BPD? There's kind of 3 triad symptoms, which are hypernasal resonance, audible nasal escape, and weak pressure consonants. And that means you can't say P's and E's with much force. And that can actually lead to some of these secondary signs, which are like hoarseness. They're trying really hard to talk, and so they're putting laryngeal strain. Some kids, particularly 22q, can have facial grimacing, and they can develop compensatory articulation errors. They can also have common articulation errors as well, but these are the 3 that you have to really think about. There's 3 first of hypernasality, audible nasal emission, and weak pressure consonants. So when you evaluate kids for BPD, you want to obviously take a history, and you want to know whether they had other things that we don't always think about. What is their otologic and audiologic evaluation? Can they hear to speak normally? These are things that we don't think about. And you really ask about signs and symptoms of obstructive sleep apnea. Again, on physical exam, you want to determine if they're dysmorphic and are they syndromic. Look at what their palate looks like. And then I think it's imperative that all these kids have perceptual speech evaluation. I think in our current society, in practice, it's gone should be the days where the surgeon just says the speech was good, trust me. You know, we should have trained speech therapists evaluating these patients. In our institution, we frequently use instrumental measures called mesometry, where they have a mirror and a computer that can test how much pressure is coming, and there's known standards and deviations from that. And then, obviously, imaging is what we'll talk about as well. When we discuss imaging, there's really two common approaches, nasopharyngoscopy and video fluoroscopy, and some centers are very focused on one or others or both. In our center, we do nasopharyngoscopy. I try to avoid radiation exposure to children. Jamie Perry out of East Carolina, she's a speech scientist. She's looking at functional MRI and whether that's going to be useful, and I think probably in the next 10 years that will also become a mechanism of evaluating BPD and velar function with quite good accuracy. So what is nasopharyngoscopy for people who don't know? It's literally a camera that you can place through the nose after numbing it up and get a great view of the velum. And this is kind of the first shot you should see when you come in. Just so everyone knows, you have your adenoid, your posterior phalanx, velum, your palaplostis, your palafringus, and your muscularis. And then when the patient phonates, you want to look at their gap location, their size, their closure pattern, whether they had previous surgery, whether they have submucous papilla. I don't know why they kicked us out. Sorry about that. And things like that. Ideally, this is kind of schematic of how things should look. It should close not just anteriorly, posteriorly, but also you should get lateral wall closure in as well. So this is kind of a still shot of a patient almost completely closed. Sometimes they can have these small central gaps, and you want to look for what's called opening. Say thank you, Dr. Bailey. So this shows.
Stop the bus.
You compare that to Gazelle, and you can see that this port is not closing correctly. Sorry. So if you do video fluoroscopy, and I kind of reserve this for children who are unable to tolerate nasopharyngoscopy, I try to get a child specialist there and all those kind of things. And you want to look at this air stripe. They do multiple views. I find this view probably the most best.